Hello, everybody. Welcome back to our How To channel. In today's episode, we have a very special episode today. So, before we get started, please like, subscribe, share all of our content. We have a lot of content coming out and a lot of content we put out in the past. So, in today's episode, this is for all our physical therapists who work in Mississippi, as well as ones who are just interested in how the profession is growing, changing, evolving. My name is Will Gray III, so I will be taking you on this journey to talk about PT direct access in Mississippi. Now, let's talk about levels of patient access to physical therapy services in the United States. As you see, this map to the right was pulled directly from APTA. And this is where they pretty much detail who has unrestricted access, who has access with provisions, and who have limited access. As you can see, Mississippi and Alabama are the two states that have the limited access, right? But that changed, at least for Mississippi, on July 1, 2024, and that was big. So let's talk about the three types of access, though, before we proceed to talk about what changed. One, we have unrestricted access, meaning that you pretty much don't have anything that governs you from seeing clients as much as you want to see them or as needed. There are some other details in there, but that's a good way to look at it. With provisions, we're talking about maybe there's a number of visits that you have that you can spend with a client, maybe 8 to 12, and then they have to get a primary care involved or a healthcare provider of some kind, nurse prac, or whomever. And then number three is limited. Limited, basically, you have no access to clients when it comes to treating them for therapy. You can do wellness visits. You can even do instructionals. You can do group meetings where you talk about certain things. You can show them things. You can even discuss their issue, but you can't physically treat them and charge them for it, right? Now, with those three thoughts in mind, unrestricted, with provisions, and limited, now we'll proceed to what changed in the state of Mississippi. And in my opinion, this is all from my perspective. And I have some perspective on this particular conversation because I am from Mississippi and I went to school here. I got my PT degree from here at the university in the state. And basically, it was time. There's a lot of things when it comes to Mississippi being last in. And as you see, even getting direct access, we were last in. And that's a whole conversation within itself of why I think was why. For me, it was just time. Mississippi finally joined the world of direct access in July 1, 2024. I mentioned that previously. And people just realized there was a changing of the guard. What I mean by that, there are younger therapists in the profession who are not staying in the state. We're leaving for the most part, and they don't know why. I can explain it to you. The restrictions that we have in this state, as well as restrictions on pay, in addition to that, the restrictions on practice, is starting to make it where nobody really wants to be here when it comes to working in rehab. And I say nobody, I don't mean everybody. I mean a good amount of therapists who actually are who grew here or born here. They tend to go into specific aspects of rehab, and as a result, most of them leave. Can't blame them. Usually they do travel assignments, and the reason you couldn't blame them because really they feel like they're bottlenecked into you know outpatient, which was paying you, very little depending on where you're located. When I say little, when it comes to compensation or being a competitive rate, it's not. I'm sorry, it's not going to work for most people who went to school and paid over $100,000 in money to secure their education. And then also, they don't want to work in hospitals. And hospitals are doing these weird things now where a full work week is 30 hours, not 40. So your hours are getting cut there because it's all about census, right? And then you have the nursing home sector, you have the home health sector, which is where most people are gravitating towards. But then you realize that there's a lot going on there. Travel is really hard on a lot of younger therapists. They have a lot more back problems, believe it or not. I treat therapists who actually work in home health who have those limitations. And then with that in mind, every state has some type of true access outside of Mississippi and Alabama. All right. I think that when you're kind of late to the party and you're trying to correct something, you're almost correcting something in a time frame where it's very hard to shift the culture of why this was hindered. And one thing I'm going to say out loud, a lot of people don't want the autonomy. A lot of therapists, whether you want to consider it, is There's a group of therapists or a demographic, whether it's age, whether it's location, whether it's just thoughts process when it comes to, being a little bit more modern therapist versus to, a therapist that was came out a lot earlier than we did. I consider myself a younger therapist. You tend to have some, how can I say this? Some reservations there. But with that, there's a collective, period. There are a collective of people who pushed it through, right? People who are in agreement that, hey man, like we had to agree to disagree on this. And there are a lot of quiet movements in the legislature when it came to passing this bill. If you followed it, it was almost like, hey guys, we're trying to do this thing. Don't say much. Just understand we have these little victories. And if we keep going this route, not being too, boisterous about it and being too verbal about it, too visual about it, that we'll be able to get it through. Now, with that, right, the next thing is what's next? I think there's four things you need to look at or consider when we're talking about what's next. What's the transition and what's about to happen within the state, um, from a standpoint of these four pillars. And for as my vision, the perspective that we need to address or things we need to discuss: health literacy, better patient care, decreased costs, more autonomy. Now, if you're a patient in Mississippi or you've been a patient in Mississippi and you're hearing this, some of the stuff I'm going to say you're not going to be surprised about. Some things I'm going to say that you may disagree with. That's okay too. It's my perspective. For me, it's not about being right or wrong. I'm just adding some eyes to the matter and try my best to get people exposed to what's occurring, what's changing within this state. Whether people agree with it, it's cool. And whether people don't agree with, that's cool too. Like I just want people to have the conversation now. I waited a long time to really speak on this. When I talked about direct access, I didn't put a video out a while ago, years ago, complaining about it. I had an issue with it, but I look at things like, well, I'm a solutions type of person when it comes to a mindset. I can't really cry over the milk being spoiled. Spoiled or spilled. I have to pick it up, right? So when we talk about the health literacy part, if you were to ask a patient or a common person, what do therapists do? Or what's our responsibility in guiding the healthcare? They would tell you is rehab or is good us giving them exercises. That is such a small piece of what we do as therapists or as physical therapists. A lot of people don't even know that we are actually doctors. And a lot of people don't even think that's of importance. I hate to crush people when it comes to this. It is of a lot of importance. Some people try to diminish it because they've been in the profession for 20 plus years, so they feel like their experience is going to supersede that. That's fine. I don't really argue that for or against that. I could care less. What I really care about, the training that a lot of us received, is a lot different. One, but two, it's also a situation where we're being tasked with more responsibilities. We can't really hide from it. But with that, if you're going to ask us to have this autonomy, we want to be able to educate our patients and give them an idea of what we do. I feel like as a therapist, we're second to orthopedics and orthopedic surgeons when it comes to our ability to diagnose and our actual mind when it comes to diagnoses. I get a lot of referrals, or I used to get a lot of referrals that were not correct. They'll diagnose something, and I promise you, it's not even close to the problem. Um, for instance, I had a patient that came to me with shoulder pain. Um, she was a breast cancer survivor, and come to find out, she was having actual a bone density issue. So she didn't have shoulder. She had shoulder pain, but it was due to the fact of her prior treatments of chemo, which in then turn led them to a bone scan. They found some things that were concerning. In essence, when I was working with her, I didn't treat her like a shoulder injury, right? But being actually aware of the fact that I need to consider, cancer and this, and not being overwhelmed because of how I like to operate, I could do what I need to do to try to get her to where she needed to go. She didn't need to continue therapy. She needed to go to her provider, her oncologist, and continue that regimen of trying to figure out what's going on. But if I'm trying to educate a patient, we are the people that you want to come to if you having an issue trying to figure out what happened with you or to you, that after an injury, after a fall, a sporting event, and you had a twist or tweak of something, and you just don't think it's basically major, but it could be. You want to get it verified. We can give you some good information to even direct you from there and say, okay, now you should do this. Or well, no, you shouldn't do that. You should do this based on these tests. What we found out, what we're seeing, you need to do these things, right? In addition to that, we also facilitate return to work, return to sport. We also facilitate other things when it comes to pelvic health postpartum. And also, we do a lot of other things in the world of actually advocating for the patient and informing the patient of the do's and don'ts, or whether or not what to expect with procedures or how to prehab before procedure. There's a lot of basically an abyss of information that I feel like is lost because you have people who don't really know what we do, right? So this is the time to educate the clients and the patients. Health literacy has to take care. I mean, has to take place now in this state, and I'm happy about that because there's too many people who are hiding behind the thing of, well, the doctor told me to do it, but you know better, or you could do better, right? Or you could say, I don't know, and let me get you to somebody who do know, right? The next piece is the better patient care. I have a lot of patients. I have a lot of patients, believe it or not, due to the type of clinic that we have here, that really get into why they feel the way they feel. Some of it's emotional, some of it's mental, some of it's physical, some of it is truly a mix of all of those I just mentioned. But the one thing they talk about is they feel like they don't get better care, right? And what they mean by that, they don't get an opportunity to get heard. People hear them talk 2 3 minutes out the room, going about their business, right? But the patient care has dwindled, and people try to figure out why. Simple. In our world of rehab, I can talk for us because I get enough therapists who have this conversation. We're burnt out. Seriously, what's being asked, what's being compensated for, what's being done. You kind of get into a phase of basically doing minimum. Doing minimum allows you to come to work, do a job that you think is a good job, and you're hoping that whatever happens after you doing your minimum, when you're signing your cookie cutter, protocol and your exercises. Whoever's gonna get better is gonna get better. Whoever's not gonna get better is fine. We're cool with that. The patient care is starting to fall off the cliff. They don't put hand on people anymore because, truth be told, in clinics, for the most part, you can't. The time crunch. Patients don't feel like they're getting the care. This change will allow them to access people who they feel like is going to give them the care and choose how they want to fund that, which in turn decrease costs. When a person gets injured, for the most part, they go to urgent care, trust care, like something that's quick, right? Or you go to your PCP as soon as you can get in with your PCP. The PCP then starts to facilitate care, whether that's giving them some pain medication, possibly being able to get them an injection of some kind, send them to a pain management. But about the time they get to us, it can be anywhere between 2 months to 6 months. We're usually the Hail Mary in in a lot of settings that are outside of physician-owned practices, which are called POPs. POPs are kind of changing their focus, though. They're more surgical driven now. So, in essence, what I'm talking about, by the time the patient starts to pay all the people they have to pay to finally get to us, and possibly we can do something, they've paid so much money. There's so much stuff that has to be unpacked, and there's so much cost they incurred. If there's an injury like a rolled ankle that is not a fracture, and anybody who's seen a rolled ankle, sometimes it's easier to determine there's a fracture versus just a rolled ankle. There's certain techniques you can use, certain testing you can use, and you're not going to be 100% perfect. But I would trust with your training, you can diagnose what's necessary and what's needed versus them having to wait, and pops never get to you, the ankle never heals, and you see them 6 months later and they have a chronic issue. And we all know how that looks. But the money that goes into that whole merry-go-round of having to see certain people before you get to us, that is going to be cut down. As a result, the patient is going to save money and to be able to take their money and kind of put it towards what they think is of importance. And then if we need to direct them to somebody else, they can go there. But sometimes they'll walk to your door and be like, yep, I don't have this. This is a fracture, compound fracture. You need to go A, B, C, and D, and they're gone. But at the same time, that does not cost the patient as much as it would to continuously go for follow-ups, and then see specialists, and then take a month to get in there, 2 months to get in there, where they have to incur costs from driving and all that. Now they can come to us if they have an injury that we can actually help with. And the last part is my favorite: more autonomy. I feel like in the world of medical practice, or like, oh, I like to call practicing medicine, right? Or practicing treatment. There is some actual give and take, trial and error that has to occur there that makes you a better therapist. But you can't get there without autonomy, in my opinion. I feel like when you're in a situation where you are restricted, or you do things that are very, instruction based or recipe based or protocol based, you don't have any autonomy, because a lot of people are just reading words, doing what's actually, in parentheses. Nobody's thinking anymore. The critical thought process is being lost. Before I even got out of school and started practicing what I'm practicing now, I can honestly say the biggest complaint for most of the CIs that I had or went to, and even when I got out and started becoming a CI, is that most students cannot critically think. They can't. And it limits them to be able to progress certain people. And people say, well, that's what the CI is for. Let's be honest here, guys. Most of the rotation these students are expecting to go on, and they want to just get an A. Most of the CIs are probably just wanting to have a student to teach them the best they can. And then after a certain point in time, they're just pretty much autopilot. As long as you can do the base function without hurting anybody, just replicate what I showed you or what somebody else showed you, they tend to let it just be. Not many CIs have the passion to teach as much as you think they do. They don't. They get in a hamster wheel of just doing things to be as efficient as possible. Doesn't make them bad people. Doesn't make them great therapists. It just makes them that, and you tend to lose some of this critical thinking, teaching in clinic. I really think that a lot of people should really focus on trying to find a system to be able to get these students to different places that actually going to challenge them and be able to get them to think. But also it starts in the classroom. There's not enough autonomy being pushed upon the students in the classroom. And then once they get out, there's not a setup where they can get the mentorship or the guidance they need to be able to become more of a thinker of, how do I approach this? How do I fix that? They usually get in a place where they're stressed out. They figure out the crap. I thought it was something different, but it's not. And then next thing you know, they've changed jobs within the past year and a half or 2 years about 3 times. They're just trying to find a place to not have to work hard, and it's so sad. But I feel like having more autonomy and having that direct access can help people become better therapists. Now, does that mean that everything's going to go great? It's going to be skittles and rainbows and Disney World? No. What it means is that this is change. With change, there's going to be some good things and some bad things, but at least we know that we're having to move on to what's next, right? And that's being more responsible for patient care and getting an opportunity to be able to treat patients for things that we don't get opportunity to see until later on. Now, with that being said, I want to thank everybody who tuned in today. Like, I want to say, thank you so much for always pressing play, supporting, liking, sharing. We're we do greatly appreciate it here in this clinic. We're trying our best to put out content and be the brain trust for a lot of different aspects within the world of rehab. This is one of our offbeat videos where we're just trying to give information about access to PT, direct access, and inform people of what's going on. As things are rolled out, we will tell you about the specific provisions. I'm pretty sure we're not going to have unrestricted access. That's not really how that works. You probably go from limited to restricted or limited to what provisions. and there's going to be a limited amount of visits most likely. But even with that, that's a change. That's a push in the right direction. Hopefully, as time goes on, well, by the time I retire, the profession has moved on to unrestricted, and we can actually get to a place where we are more autonomous and we're better at critical thinking and being able to help the clients and the patients to understand their diagnoses, get back from their diagnoses, and be able to share that information that we give them. So, for everybody who want to continue the journey with us, please like, subscribe, share the content, right? Follow the channel. Be on the lookout for more. We're going to try to do one video a week going forward. I kind of slowed down a little bit after June 6th, but stuff comes up, you get busy, but we're back. So, thank you. And with that being said, I hope you have a blessed one. We'll catch you in the next one.